Hi, everyone. Welcome to our multi-heart lecture series. It's a pleasure to have today Dr. Leticia Fernandez-Pereira. Dr. Fernandez is the Director of Advanced Cardiac Imaging at HM Hospitales in Madrid, and she's also the Chief of Cardiology for the department. She started also the Atria Clinic Foundation partner, where she focuses on women's health, and she will be speaking today about the use of hybrid imaging with PET-MR. Dr. Fernandez she trained at ECHO at MGH, and then she did an additional training on CT-MR at Mount Sinai here in New York. She's very well published with over 100 publications, including 4 Nature, 24 JACC, 7 Circulation, New England Journal of Medicine, and European Heart Journal. So it's a pleasure to have you here today. Thank you so much for taking the time.
Thank you very much, Leandro, for the presentation. Thank you very much, Aldo. It's my pleasure to be here. I would like to mention also Mario Garcia, who is my teacher, and thanks to him, I'm now working on CT and MRI most of my time. So today we are going to talk about cardiovascular hybrid imaging using PET and MR. First of all, I would like to introduce where I come from. I work basically in Madrid. We are HM Hospitales. We are around 10 hospitals in Madrid. 4 of them have an advanced cardiac imaging program with several CTs and MRIs and 1 PET MRI system, which has been installed 6 years ago. And then we also work in the north of Spain, in Barcelona, in the south of Spain, in Galicia, so we are all expanding. We are a big team. This is our cardiologist team. So we would be happy that anyone who is interested in visiting us to receive them and then try to complete also imaging training with us, or as Leandro and Aldo were talking about before, establish a nice collaboration in exchanging fellows or rotation. And this is our Atria clinic. So I think it's important to show some pictures before starting to get to know where we come from, where I come from. So I divide the talk today in these 4 aspects. What is the MRI systems? How we should use these systems, when we have to use them, and who are the patients who will benefit most from these kind of images. Let's start what is PET-MR imaging. So we know that there are different systems in the market. Before, we used to have these kind of Philips systems that have the board from MR and PET separated. And then there was a table in the middle who rotate the patient to get, first of all, the MRI images, and then the table moved to get some PET images, because it was impossible to have in one country the PET and the MR technology. So we have the first system in the world in the Mount Sinai Hospital like 15 years ago, and then we were struggling with the images. And it's true that the images were not completely fused, because then in the post-processing work, we had to put the images together. And then the technology advanced, and other systems came to the market, putting together MRI and PET technology in the same country. This was an important advantage because we could really work with fused images, and the patient could benefit in the same study from both MR and PET, and the studies were not so long, because before the studies were very long. First of all, we acquired MRI and then the PET study. What is the PET? The PET needs always a radio tracer. It needs something to be synthesized most of the cases, the radiotracer needs a cyclotron near the center where the PET is being acquired. So the main radiotracer that is being used for cardiovascular imaging is the FDG radiotracer, which is glucose with fluor. So first of all, this radiotracer needs to be synthesized in a cyclotron, and then once we have the fluor radioactive, it's combined with glucose, and then it's injected into the patient. We need to wait some time until the radiotracer is distributed in the whole system, and then the signal from the radiotracer decays, it releases positrons and electrons, and then the PET obtains that signal that comes from the radioactivity radiotracer, and then the heart release some radiation, and the ring from the PET gets the images. What are the main differences between SPECT and PET? Most of cardiologists are familiarized with SPECT, but PET is something more new that comes from oncology. So the PET has higher spatial resolution than SPECT. SPECT sometimes cannot detect small infarcts. The PET allows us to perform some quantitative evaluation, while SPECT is only qualitative evaluation. PET gives us molecular information, basically about inflammation. This depends on the radiotracer we use. And we can also obtain viability information, perfusion, or about the adrenergic system. It gives less radiation than SPECT, especially if we calculate or quantify the dose of the radiation depending on the weight of the patient. And then we always try to inject a very small amount of radiotracer to save radiation. And it's very good to detect coronary artery disease with high sensitivity and high specificity. And also including viability to identify viable or non-viable scars. And what about MR? We all know that the MR is a big magnet. So it uses magnetic field. We have different strength, 1 Tesla, 1.5, or 3 Tesla. It uses water, so it's based on the hydrogen properties, and it needs radio frequency pulses. So this is a very simple way to summarize MRI, what we need to obtain MRI images. So when we obtain the images, actually, when the energy release and when the tissues relax. So once the patient is into the magnet, and then we put on the radiofrequency pulses, all the hydrogens and the water molecules are excited. And then once we turn off the radiofrequency pulse, the energy is released, and in that relaxation progress, the image is obtained. So we can perform MR without contrast to obtain an estimation and quantification of the global left ventricular and right ventricular function. We know that is the gold standard for this. And also morphology processes to detect inflammation in terms of water, or also fat, or also iron. But we can obtain these images without contrast. And also we can perform the MRI with contrast to obtain perfusion with high sensitivity and specificity, and delayed enhancement images to define whether a scar is viable or not viable, and then the transmurality and the location of the scar. So the message here is that MRI also can be performed without contrast, and then we also can obtain some information. But the PET cannot be performed without radiotracer, and it has some radiation associated, less than with SPECT, and the MRI has not radiation. What someone thought that PET and MRI should be fused. With it, we always say that PET MRI is a perfect couple, because the MRI, as I explained before, we can obtain anatomical and functional information, whereas with PET, we can obtain metabolic or inflammatory information. So the MRI has great spatial resolution, anatomic definition, and tissue, and the property to perform tissue characterization, whereas PET is very good to detect inflammation thanks to molecular imaging. Let's move to how we perform PET MRI. As I told you before, we need another radiotracer. It's very important to know the accessibility to have that radiotracer, the half-life, and the target. What we want to see. Depending on the process we want to target, we will use one radiotracer or another. As I told you before, the most common radiotracer, and is the one we use in the hospital, is the FDG radiotracer. There are other radiotracers with carbons or oxygen, but they are not so long approved by the FDA. What is very important is to have a very nice patient preparation before the test. Sometimes the patient comes and it didn't follow a proper diet, and then the images cannot be diagnostic. So I always say that it's very, very important, this part, and all nurses, call center, cardiologists, internal medical doctors should be work in a team. We also recommend the patient not to perform physical activity the 2 days before the PET-MR, not to get a lot of uptake by the muscles, because sometimes it can be difficult to obtain, especially arterial, good quality images. And the diet preparation depends on what we want to see. If we want to evaluate viability or metabolism, what we want is to achieve that all myocardium takes the FDG. It's meaning that we need a myocardium with a lot of uptake. Normally, we inject insulin in these patients to achieve a glucose overload. So in the images, in the PET images, we see the heart very dark. On contrast, if we want to target inflammation, we want to make the heart disappear. We want the myocardium without uptake, because if there is some myocarditis or there are some tumor, we want the tumor or the myocarditis to bright, not the heart. So that's why if we want to see viability or scar, some dead tissue, we want to make it different from the alive tissue with uptake. So it's very important to analyze all the requirements for the study before we plan a PET-MR study to prepare the patient. So there was a long way to run with the PET-MR because the CT, when we use PET-CT, the CT gives very good attenuation for each tissue. With CT, we know what is bone, what is air, what is fat. But with MRI, we don't have the Hansfield unit intensities for the tissues. So the machine didn't recognize what is water, what is air, what is fat. So it was difficult to get good attenuation maps. These maps have to be performed in all the exams. First of all, there were maps for 3 tissues. Now we have maps for 5 tissues, which is the advisable maps to have. But this was very difficult to achieve from the engineers. What is basically our protocol in the hospital? So we receive the patient, we inject the radio tracer. As I told you, we use the floor FDG radio tracer in most of the cases. Then we have to keep the patient in a quiet room to wait for the radio tracer to spread along all the body. We tend to wait around 40-45 minutes. And then if the glucose is okay after a glucometer analysis, it has to be under 200, we can start the PET-MR study. It depends on what we are going to do. If we want to find viability, if the glucose is not 200, we might inject some insulin. But anyway, the study starts first of all with the localizers, and then we start to plan the PET images. We set normally 1 bed to cover the heart, and we put in the system the dose and the time when the radio tracer was injected. And then we start to acquire the PET images immediately. While the PET is being acquired, we start the MRI protocol. We start first of all with the MR attenuation maps, and depending on what we want to look for, the protocol changes. But normally we always perform the thin function, the thin sequences, morphology, perfusion depending on the case, and then the delayed enhancement. Normally, the complete PET-MR study lasts for 60 minutes, and then the patient can, leave the machine, and then we will read the study. Because the radio tracer half-life is very long, so that's why this radio tracer also works very nice for cardiac studies. If we want to use another radio tracer with less half-life, it might be problematic because we cannot get enough signal at the end of the study when we perform these cases. As you know, cardiovascular PET-MR has been explored for clinics and for research. For clinics, and unfortunately, there are very limited evidence because few centers in the world have this kind of system. So we can say that although we don't perform much studies, we are doing well because, for example, in Spain, I think only PET-MR is performed in Barcelona and in our center. So very few centers do it. And then, of course, you can always use cardiovascular PET-MR for research. So these are the kind of indications you can plan to have a PET-MR study. Basically, you can study ischemic cardiomyopathy to evaluate viability, including function, delayed enhancement, and also the signal from the radio tracer, area at risk, and also to evaluate remodeling post-myocardial infarction in acute and in subacute phases. In other cases, you can also evaluate non-ischemic cardiomyopathy, And then the main indications we use this kind of studies for are to evaluate inflammation, myocarditis, and sarcoidosis, also to evaluate infection in cases of endocarditis, to evaluate tumor, basically to understand if it's primary tumor or secondary tumor, and also to evaluate atherosclerosis or vasculitis. So when you face the patient and you think, I'm going to do a PET-MR, as I say, you have to say what you are looking for, non-ischemic or ischemic, because the preparation changes and the protocol changes. So let's see each of these indications. For ischemic cardiomyopathy, we can evaluate viability in a very nice way using multiparametric information to assess function and also delayed enhancement. So it helps to define subendocardial scar and also transmural scar. So we were starting a project, well, we are not starting anymore. We are doing a project to evaluate intermediate viability, because I think that it's very easy to know if it's non-viable or viable in cases when the transmurality of the delayed enhancement is less than 25 or greater than 75. But what about those cases where the delayed enhancement is intermediate between 50, 70, that you don't know if the heart is going to recover? So I think in those cases, the viability performed by PET-MR can help a lot, because it adds the MR information with the PET information. We published this nice case where the MR images was not very clear whether it was transmural or only subendocardial, but then with the PET images, there was some signal. So we conclude that there was some viability in that myocardium, and this patient recovered the function after surgery. So in these cases, I think the PET-MR can help a lot. Also about quantifying the area at risk in reperfused infarction can provide information. At the same time that you have the information with the MRI, by using the T2 maps or using the STEER, you can add the information from the PET in the same protocol. So it adds nice information. In the remodeling is something that we are starting to explore also in the hospital, because it detects acute and subacute inflammatory changes post myocardial infarction. With MR, we only evaluate the delayed enhancement or the function, but with the PET, we can add if there is some activity, or there is still some activity in that myocardium. So we can predict how the heart is going to remodel in the future. Also, it's important to monitor cardiac therapy in these cases, because if you perform the PET-MR after infarction and then after 6 months, you can evaluate changes in the PET signal, in the inflammation. Also, in this nice study, they evaluate only 50 patients, but it was a nice series, and they perform a PET-MR, and they also evaluate information from PET or from MR, and they conclude that hybrid imaging prior to revascularization shows a better diagnostic accuracy than if you use PET or MR alone. So they encourage to use PET-MR before you are thinking about opening a chronic coronary total occlusion, that sometimes we don't know what to do with them, whether to open them or not, and then adding PET to the MR improves the diagnostic accuracy of good results. What about non-ischemic cardiomyopathy? It helps. Yes, it helps. It helps, as I told you, in myocarditis, sarcoidosis, endocarditis, tumor, arterial disease, because it gives diagnostic information, especially when you have incongruent results from other imaging techniques. It gives you also information about disease extent, not only if the heart is affected, but also if the spleen or other organs are affected. And sometimes it confirms what you have seen in other techniques, but that's information. Besides diagnostic information, it provides also prognostic information, especially for the follow-up of the patients and for evaluating response to therapies. Let's see each of these pathologies. For myocarditis, it's very nice, PET-MR. We perform a lot of these kind of studies for myocarditis, especially in acute phases when the delayed enhancement and the edema might be still negative, because the FDG uptake is very nice in these early phases. Also, we have some cases, on diagnosis recurrence myocarditis, when the MR gets very limited, because sometimes the steer is not positive, or we don't know what's going on, and the FDG can give us information. And it helps also to evaluate the response to treatment, whether we have to stop the anti-inflammatory therapy, for example. It has been published that PET-MR is feasible in myocarditis, and the diagnostic accuracy of this in this pathology is increased when you add the PET to the MR sequences. For example, here, the NENSA, which is also a very nice researcher on this topic, but he published a lot on PET-MR. They saw that the adding PET and T2 weighted images has better correlation than only having T2 weighted and delayed enhancement images. The STEER and the PET gave the best correlation, even better than the delayed enhancement and the PET images. So in patients with MRI, we have to be confident with this technique. Also for sarcoid, probably is the most, the better pathology to have performed this kind of test. We all know that sarcoid is very difficult to diagnose with MRI because it mimics any kind of delayed enhancement. And then cardiac involvement indicates poor prognosis. So it's important to detect cardiac sarcoid, especially at early stages when we can initiate treatment. The PET-MR is good for diagnosis, but also for prognosis, as I say, and for monitoring response to treatment. In this nice table that is very useful, we can see how we can conclude a report depending on the results on delayed enhancement or the FDG. If these tests are both negative, we can conclude that there is not sarcoid. If they are both positive, we can say that there is active sarcoid. But what about if we only have positive delayed enhancement and negative FDG? We can say that it's a null process. And then all the way around, if it's PET positive, but delayed enhancement is negative, maybe we have a false positive. In this paper, they confirm again that the combination of PET with MR, both using T1 and T2 mapping imaging, can detect much better the diagnosis and the prognosis of any suspicious cardiac sarcoid. So they tested in patients with confirmed cardiac cycle. And again, they say that FDG can help to localize what delayed enhancement is active or is not active. So it can depict the inflammatory processes. In some rare cases, when we don't know how to evaluate inflammation, PET and MR are definitely very good because PET has not good spatial resolution. So sometimes we see some signal, but we don't know where it's coming from. And then there is where MR comes to locate exactly the high intensity signal from the PET. So in these cases, there are few literature in this matter. They published the utility of PET-MR in Laufer syndrome and also in fibrosis endomyocardial. In case of infection, we know that recent guidelines include PET-CT evaluation in some patients, especially with devices where the echo cannot help much, or even in recurrence, or even when the diagnosis from echo is not so concluent. So in cases where the infectious is the prosthesis, as long as it's MRI compatible, this technique can add a lot of information, especially for diagnosis and monitoring treatment. What about tumor? Tumor the same. It helps a lot to define whether it's primary or secondary. And besides that, we can obtain very nice images. We have published this case with a patient with an angiosarcoma where the PET images and the high intensity from the PET-MR didn't give any doubt that the tumor was malignant. And sometimes with the MRI, we have some questions, and it's not easy, as you know. Also, the PET-MR can be used to detect different types of vasculitis, especially if the disease affects large vessels. So it adds information, the PET together with the MR, and then the fused images helps in the diagnosis and in the evaluation of the progress. Also about atherosclerosis, with MR, we can identify the plaque. We can see if it's fibrotic content or lipidic content, but we don't know if it's a high-risk plaque. If we add PET, if we add imaging with FDG, we can evaluate if the plaque is lo que llamamos hot, or if the plaque is not taking the FDG, we call a cold plaque. So in few words, it can identify high-risk plaques. If there are some high content of macrophages that is taking the signal from the glucose, and then we see it like bright. In this image here, we see uptake in the vessel, which indicates that there is a high-risk plaque, whereas in this other image, there is not uptake at all, and the risk is lower. Besides qualitative evaluation, we can also quantify how much inflammation there is in our plaques by using standard uptake values. The problem is that there are different parameters here, mean, maximum, TBR, which normalize the signal from the vessel to the venous activity. So we also have the target background ratio, mean, maximum. So there is quite controversy to see which parameter is best, although it seems that the best parameter is the TBR mean value. In this sense, we wanted to evaluate what's going on with the vascular inflammation in a healthy cohort. That's why we use the PESA cohort study to evaluate vascular inflammation in patients with subclinical atherosclerosis, and whether the PET-MR systems could help us to identify those high-risk plaques. We use this protocol. We inject the FDG radiotracer, we wait half an hour, and then we perform the lower body PET-MR study and then the upper body PET-MR study. What we saw in a cohort of almost 800 patients who underwent a PET-MR study is that the atherosclerosis, with atherosclerosis, already atherosclerosis, we saw that arterial inflammation was very commonly found. 1 out of 2 patients have some kind of uptakes. It's true that we look at many vessels and many arteries, and this cohort had already atherosclerosis. And what we observed is that the most inflamed plaques were located at the femoral territory. So this was a nice finding. Then we tried to correlate which was the risk factor more associated with inflammation. And besides male sex and age, we found that the smoking and obesity were the main risk factors associated with inflammation, according to what had been published. And in an attempt to localize those more inflamed plaques, as I told you, we found it in the femoral territory, and then we found these plaques at the bifurcation levels, and these plaques were also more lipid-rich content. So it was in line with the publications. And this was, the PET study in the PESA cohort was more a research study. And then we wanted to evaluate whether the PET-MR was useful in a clinical scenario. So we published this paper based on our own experience in the hospital. We wanted to evaluate whether adding PET and MR to our patients provide better diagnostic accuracy than performing only PET or only MR. And then we divide our patients in 2 groups, one coronary group where we include 30 patients, and then another non-coronary group. In the coronary group, we observed that the PET-MR was useful in 42 patients. Then in this figure, we evaluate how the PET-MR changes the diagnosis over the MR and the PET. And then in the non-coronary group, we observed that the PET-MR was much more useful. And then when we didn't know what was going on in the MR study with no diagnostic at all, adding the PET-MR improved the diagnostic capability of this test for our patients, and then we could conclude what was going on. And then especially for the MR, here you see that the MR say we don't know in many cases, and then the PET in these cases was better performed, but in some other cases, although the PET was not concluent, it also improved the diagnosis. So in summary, using PET-MR helped in the diagnosis of 3 out of 4 patients in our cohort. So this paper helped a lot cardiologists and other kind of specialists to request this test. So I recommend you also to publish your series and also showing what you are obtaining also to your colleagues to initiate the program. So finally, to give you some take-home messages, we know that PET-MR is a perfect couple because it's a winner. PET adds information and can go over MR limitations, and also MR limitations are covered from PET because it provides a fusion of anatomy, function, and metabolic information. We have to select what radiotracer we want to use. It's important to have a cyclotron near your center. The most used radiotracer worldwide is the 18-fluor FDG because it links glucose with fluor. It has a long half-life and it's easy to detect inflammatory and metabolic processes. It's very important to prepare and in a proper way the patients, whether you have to do an overload in proteins or in lipids to change glucose metabolism according to the indication of your test. If it's ischemic cardiomyopathy, it will be different from if the reason for the scan is non-ischemic cardiomyopathy. And it's very important. It's very complicated to have a null the signal from the myocardium in case of myocarditis or sarcoid, especially for diabetes. So this point is crucial. And then you have to use for sure attenuation maps to get good signal and to get good values from standard update values parameters. And then basically the main indications for these tests, as we were talking throughout the talk, are non-ischemic cardiomyopathy, especially myocarditis, sarcoidosis, also endocarditis, it can play a role, also tumors and atherosclerosis, and for ischemic cardiomyopathy, especially viability. So PET-MR provides very nice pictures, but it goes further than nice picture. It provides more information for our patients, and this is very important to optimize the treatment. Thank you very much for your attention. My pleasure and my invitation to come to our center and see in situ cases. Thank you.
Thank you very much, Dr. Fernandez. That was wonderful. Please put your questions in the Q&A and we'll go through them. I'm sure you have some. I'll start with one question. You mentioned a little bit about these patients that may have discordant viability with PET and MRI. How do you deal with those cases? One study suggests viability and the other one suggests that it doesn't. And which patients you see this more often? Is it diabetics? Or?
Yes, most of them have to be with the preparation because you have to be very demanding with the PET quality. So, well, actually we come from MRI. So that's a good question because sometimes with the nuclear doctors, we were discussing which one should win. And I think most of the cases, the MRI has the reason, but I think because there was some problem with the PET images acquisition. And sometimes we just conclude that viability was intermediate. So we focus more on the function, other parameters besides the inflammation information. And
I like that concept.
Diabetic for sure were the most complicated cases.
I like that concept of viability as a continuum and not a yes or no as well. So very good. So Mario says, hi, Leticia. And he has a question. He says, what is the advantage of doing the two studies combined versus separately? Do you save any time?
Of course, you save time, you get more information, you work in team with the nuclear doctors. I think all are advantages for sure, because the study is 45 minutes or maybe 60 minutes if you extend the MRI protocol, but it doesn't last more time.
Very good. There's a question from Dr. Chavin, or Director of Nuclear Cardiology here. In Spain, he asks, is cardiac PET-MR largely a research tool or is it widely clinically used?
More as a research tool.
So,
but
yeah.
I think it's more like a problem of availability and expensive system. So I think the commercial market should be more competitive and make easier to have access to these systems, to more centers. I think that's the main problem, not the usefulness.
Great. Yes. Hopefully, we'll see more around. When you do stress, do you do the stress part with the MRI or with PET when you do combined?
We do stress with MRI, but we don't do many stress PET MRIs. to tell you the truth. But then we are starting to explore that case, but stress with MRI.
If you have to see, in those cases, if you have to see microvascular, if the idea is to measure flows, do you think any of those would make you choose one versus the other? Or?
The thing is that we use FDG as radio tracer. And then if we want to evaluate perfusion or other kind of process, we should change the radio tracer. And for us, it's very useful to use FDG. So FDG has also their limitations.
It probably keeps the cost lower to use the MRI for that part.
Yes.
Okay. So Dr. Garcia is asking, in those cases where you saw extensive plaque inflammation, did you see a correlation with biomarkers such as high sensitivity CRP?
Not really. It's something that we are studying. We don't know if they are acting in different processes of the disease, but only, well, actually, it was when we found a high burden of inflammation. Let me explain myself. If we only see one plaque inflamed, there was not a nice correlation. But if we saw a lot of vessels inflamed with many plaques inflamed, there was a nice correlation with PCR.
That's very interesting, actually.
It was nice to evaluate burden of vascular inflammation.
Yeah, so you may miss it if you use only CRP, probably if it's in the lower.
Yes. Yes, we divide it in different groups.
Very, very interesting. So there's no more questions, I think. So thank you very much for the lecture. It was a pleasure, and hopefully we'll see you in person soon.
Yes, yes, yes. That's for sure. Thank you very much for the invitation. It's my pleasure. And in August, I'm going to New York, and hopefully we can meet personally. And then you are, of course, invited to our center, and then let's start a nice collaboration.
Thank you. I agree. Have a good weekend.
The same to you. Bye.